So I think we are now live on YouTube. So basically, this is a class concept which we have got, keeping into mind, as Shilpa madam has said, the sonography picture, the anatomy, and the surgical picture. All the three correlation happening simultaneously. Okay, so what this is going to do is, we are going, these are going to be slightly large classes, as Shilpa madam said. So please bear with us. I will start with the anatomy very quickly, followed by which Visma is going to be taking over and he is going to be explaining the entire sonography. After that, we will be trying to show the exact surgical picture inside. Okay. Once we show this surgical picture from inside, then we can have a question answer session. And I think this will help us correlate almost everything to everything. Okay. So I will initially begin with my sharing of the screen. Shilpa madam, I just hope my screen is visible to everyone. Yeah, I'm just starting with the screen sharing here. So you can see my screen, I hope, right?
Yeah.
So when you see my screen, the most important thing, today's topic is abdominal wall endometriosis, right? So what is the abdominal wall that we are trying to look at? So this is the umbilicus, okay? This is the layer of the skin, all right? And this is the pubic symphysis here. So basically, when we are trying to talk of this particular disease, we are trying to talk of endometriosis, which is present in the abdominal wall, typically at a scar site. So this scar site is going to be, of course, the lower segment caesarean scar or in and around it. Okay. So what is important for us to remember is that after we cut the skin, in majority of the Indian ladies, you are going to find a good amount of fat. Okay. Especially in the lower abdomen. See, there is a joke around this. Okay, we continuously play this joke that even if the Indian lady is on continuously dieting, I have so many of my friends and colleagues and gynec friends who are perpetually 5 years they've spent doing dieting, but nothing happens to the fat layer. Okay, we do not know why. Okay, so remember, when you open, the first thing which you see is the fat. Underneath the fat, you will see a small fascia. Okay, when you cut open this fascia, another there will be deep layer of fat. And inside this deep layer of fat comes the most important layer which you are going to see, and that is going to be the rectus sheath. When you cut open the rectus sheath, underneath the rectus sheath, what is visible to you is basically the rectus abdominis muscle. Underneath the rectus abdominis muscle, you have, till this region, you have the posterior rectus sheath. Okay, this is of course then going to merge with the fascia. And underneath the posterior sheath, you have the layer of the peritoneum. So whenever we are trying to talk of scar endometriosis, friends, usually what we see is the scar endometriosis is present somewhere here. Okay. Now, on ultrasound, we are trying to determine the depth of invasion. Why are we trying to determine the depth of invasion? Because for us, determining the depth of invasion, especially at the layer of the rectus sheath or in the layer of the muscle, or completely involving the peritoneum, is extremely important, because this helps us in planning the surgery. As Shilpa madam said, we did so many cases in Bangalore itself of recurrence, right? So remember one thing, the recurrence happens because you have tried to, first of all, the magic drug which all people give in our country, that is Dynogest. So remember three things, and this is even if you are a patient. Remember, if you have been fooled by giving Dynogest, if you have been given this new cute little thing called elagolics, if some stupid has put Mirena inside you, or if somebody has gone one step beyond all of this and has given you Luprite depot, and in some villages, I have seen people who have really lost their mind and they have even administered DMPA to the patient. In all these situations, what is going to happen is the patient is simply going to do this. The patient will leave you and the patient will go to a specialist. So the most important thing which you have to realize is, if you don't want the patient to leave you, you treat the patient correctly. In order to treat the patient correctly, get your diagnosis right. Because if there is a scar endometrioma or an abdominal wall endometriosis, which is typically more than 1 centimeter, associated with pain, then the treatment of choice for that patient is only to operate. Okay. By giving all these drugs, you are simply increasing our work and referring more and more patients to us, because majority of these patients would come to us directly if you are not able to refer them, because the knowledge which is available, forget Google, Chat GPT also states the guidelines very beautifully. And if in case you have to be surviving in your practice, you have to understand the anatomy and understand the disease correlation. How do you correlate this disease very nicely? You take a beautiful probe, and this sonography probe is going to be kept on the abdominal wall. The best way to do this ultrasound is by using something called as a
Surface probe.
small part probe, or also which is called as a surface probe. Okay, these two things. Okay, it is a simple probe setting which is available in almost all the probes which are available across the ultrasound machines of the country. And you must take this configuration to diagnose the superficial uh, abdominal wall endometriosis. This finishes the understanding of anatomy. Now we go to the Vismay. I can play the ultrasound video for you, Vismay, and you can ask us to stop wherever you want us to stop. So I have downloaded that video for you.
Yeah.
Yeah. So again, I am going to be sharing the screen, and now Vismay will be speaking about the ultrasound. So kindly help me know if my screen is visible to everybody.
Yes.
Okay. So this is the ultrasound. Okay. This is the ultrasound which Vismay has done. Vismay, if you want me to pause, I can pause.
Yeah.
Can everybody see my marker?
Yeah.
Yeah.
Can
So we will pause here. Yeah.
Okay.
So we will just we will just see the layers of the abdomen here,
Yeah.
and which you have shown previously in the drawing. So the topmost layer which you are seeing is the skin.
This is the skin, right, Vismay, on my marker?
Okay. Yeah.
Okay.
So that is skin. The fat layers is the the wall structures you can see below that. All the structures which are hyperechoic is the fat. Okay.
Vismay, the hyperechoic structure is also
Anyone
called as the
wants to
white
remember,
structure. All this, what is white,
yeah,
is
but to be
hypoechoic. Yeah.
sonographically correct, it's more of hyperechoic. Then you can see the layer below that, the white line which is seen.
This line.
Okay, which is actually the nodule is interrupting from left to right. The nodule is in the middle, and the left to right, the white line which the nodule is interrupting is the rectus sheath.
This is the rectus sheath, right, Vismay?
Yeah, so that is the rectus sheath, and below that you have a hypoechoic compared to the above layers, or compared to the rectus sheath. That layer is the rectus muscle layer, which is somewhat the consistency is somewhat, you can, if you want to compare, it can be compared to a uterine muscle too. It looks basically the texture is the same, and the lower is the peritoneal layer. Okay, and below it will be the peritoneum.
This is
So
the
these are the
preperitoneal
structures
layer.
which you can see. Yes, sir. So these are the structures which you are able to see in a flat probe, or the surface probe as we call it. And yeah, you can start the video, sir.
Okay, thank you. You can ask me to stop, okay, Vismay, whenever you want.
Yeah, sir. Yeah. Sir, just a backup, sir. Thoda, yes. This is fine, sir. This is fine. Yeah. So here now we can see, actually we are seeing the whole nodule in this video. Okay. So how you can differentiate from the normal tissue? Okay. You actually start from the tissue which is normal. You can see all the layers, and as and when you reach the nodule, you will see this hypoechoic, which is black from the surrounding regions, and it is not very regular. The margins, as you can see, are very irregular or spiculated, and they are present in all layers. It can be the involvement of the skin, the fat, the sheath, as you can see, and here the muscle is also involved. Okay, the main point is to remember that these nodules can be also very small. Okay, and they ideally a scar endometriosis is a very irregular region. Okay, when you see a very small lesion, sometimes in the subcutaneous fat or in the rectus sheath, which is a small round dot, regular margin, the main differential diagnosis you should also have is something called as a scar granuloma. Okay, the stitch which must have been taken during the surgery, previous surgery, it could be anything, a cesarean or any other abdominal surgery. The stitch has not got dissolved properly, and it has also turned into a scar granuloma. We have had one or two cases where the history is very important. If the patient sometimes know that what kind of a stitch has been taken on their abdomen, if they say that some non-absorbable stitch has been taken, that could be a scar granuloma, and it should be one of the differential diagnosis for a scar endometriosis. Okay. In this particular case, you can see the upper margin of the nodule, the upper margin, as you can see, it is going towards the skin. So what is happening? There is it's an inverted, it's a pyramid-like structure. So the base is wide and the upper borders are going and thinning out to the skin. Okay, this is actually a sinus tract formation which is happening. If this patient would have waited for some time, this would have opened. Okay, and it would have started discharging pus or sometimes even blood from the scar site. And when that happens, then that whole tissue layer, whole layers are gone. And instead of just a very small surgical incision to excise this nodule, you have to perform a whole laparotomy, and you have to excise the whole incision and refashion it. Yeah, sir, you can start.
Vismay, this is that sinus tract, no? Which is coming
Yeah,
inside.
this is the sinus tract, yes, sir. The upper above the sinus tract, yes. And you can see here, it is definitely, you can see that the rectus sheath is definitely gone because there is an interruption from, if you go from left to right, the rectus sheath is interrupted by the nodule. It is also involving the rectus muscle here. Okay. You calculate the standard measurements where you calculate the depth of the nodule from the skin and also from the preperitoneal layer here. Okay. These are when the preperitoneal distance of the nodule is in form of less than 1 centimeter. Okay. There is a very high chance that during the excision, because we maintain around a 1 centimeter margin from the nodule peripherally, circumferentially, when we remove the nodule. As a surgeon or as a radiologist, you should inform the surgeon that there is a very high chance that the peritoneal layer might open or you may enter the peritoneum in such cases. Okay. You can try to have a 3D reconstruction of this, but I think you can just draw it. You can have a volume of it so that you can have a very good picture of how much rectus sheath will be removed in this case. And so if the mesh is required or not, you can have you can pre-counsel the patient about that.
Okay. So at this juncture, I think it is very important to understand one thing, that if the rectus sheath has been cut open by more than 2 centimeters, reconstruction is only going to happen with the help of mesh. There is nothing else you can do. You can't pull the rectus sheath. If you pull the rectus sheath, it will simply cut through. That is a very big problem. Okay. So just remember that. I am going to be again going to the surgical correlation now. Anatomy is finished. Sonography is finished. Now I'm going to the surgery, and of course, then we will be answering questions. Okay. So I am again going to the screen sharing, and I'm going to be trying and showing this hopefully very, very quickly, because I did not get all the videos. So whatever I had, I have just tried to get them. So let me just show. Right. So can you see this? Can everybody see this?
Yeah.
That is the muscle which I am cutting with the help of monopolar. And the nodule is there. Can you see? So the muscle is intact. As Vismaya stated, posterior peritoneum is intact. Nodule is a big nodule, around 4 centimeters. And you can see the whole nodule is out there. The same thing, you are cutting the nodule, leaving the free fat behind. Okay. I'm cutting through the muscle there. I'm using simple monopolar. People can use sharer. People can use harmonic. You can see that whole nodule has gone. Okay. This is that entire nodule. So if I try to just cut open the nodule and show it to you, it will correlate exactly. You can see the fat around it. That entire fat comes out as margin, and you can see this entire large nodule. Okay, which we have removed out completely with free margins. So you can see the nodule and you can see those free margins there. Of course, friends, what's going to happen is that the reconstruction for all of this is going to happen with the mesh, because it was a 4 centimeter nodule which took off the entire anterior rectus sheath. Okay, so when it takes it off, the entire reconstruction happens with the mesh. These are proline sutures which you are going to be using to anchor the mesh inside there. Okay, you can see that the mesh is getting anchored there with the help of proline sutures. Okay, and once the suturing and everything is complete, we are going to leave an abdominal drain inside, and after we leave an abdominal drain, that is when we are going to come out. Okay. Again, before I start the questions from Shilpa Madam, Aarti Madam, and from Vismay, there is one very important message which I think everybody should know as far as this particular situation is concerned. For God's sake, make sure that you do not give rubbish excuses to the patients. Okay. This is the commonest question which we have been asked. So I will answer all the common questions first. Okay. Is it mandatory to do MRI and not do an ultrasound? Remember the ACOG guidelines, because all of us are absolutely, we are such highly academicians that we want guidelines, correct? No. And we don't want to follow them, but the guideline states ACOG 2026 February guidelines. Ultrasound is the diagnostic modality of choice. MRI to be done when you don't know how to do an ultrasound or you are suspecting deep endometriosis. So do not unnecessarily push your patients towards doing an MRI, because MRI of the abdominal wall, unless you have specified, even the radiologist may miss out on certain small lesions which your ultrasound probe won't. There is no manner in which a routine abdominal probe or a routine transvaginal probe can be put on the skin, because the frequency of the piezoelectric crystal which is present out there is low frequency, and that allows us to evaluate in depth. These are small part frequencies. So small part probe has a very high frequency which reduces the distance of evaluation for the probe, and that is the reason why you have to choose a small part probe only. Okay, that is important. One point I want to mention, quite a lot of times in these nodules, and I think Vismay can correct us, in these nodules you will have vascularity. These are nodules which are going to have minimal amount of vascularity inside them, and it is not compulsory for these nodules to be painful and tender. It is not compulsory. These nodules may be painless nodules, so just remember that as well. When you put an abdominal drain inside, okay, make sure that it is a vacuum drain so that the skin and the fat layer approximates over the mesh. And after you do this, if in case it is deemed to be necessary and recommended, you are most welcome to recommend the patient to do physiotherapy. Final question which everybody has, and I think it is the stupidest question which the patient is told. Majority of the patients are told, you try for pregnancy and this nodule will go away. Remember, with the nodule being present, making somebody pregnant is an criminal negligence. Remove that nodule. If a mesh has been kept, this time if I am coming to Bangalore and if Shilpa Madam allows me to come inside her hospital, we are going to be doing a cesarean section for a lady in whom we have done a massive scar endometriosis correction, and we have put a 15 centimeter mesh. Okay. And we are going to do a cesarean section by simply cutting through the mesh. Fibrosis would have formed. You can cut through the mesh, and like how you are taking routine sutures, closure of the rectus sheath can be done just like how the closure of the mesh is to be done. So do not get worried about all those types of situations. In advanced cases, because majority of the cases who will come to us are going to be advanced cases, you may also see invasion of the skin, and simultaneously you may also see invasion of the bladder. So invasion of the bladder or invasion of the anterior wall of the uterus is very common. Okay. So with that, I guess I finish everything. The floor is open for questions from Aarti Madam and Shilpa Madam. And then if time permits, we may have more questions from the audience.
Okay. Jay, can I just share a few images?
Yes, madam, please.
Okay.
Uh,
You have to
Screen
allow
sharing.
me.
Yeah, screen sharing is allowed.
Okay. Okay.
Yeah, we can see your screen, madam.
Yeah. So just one thing, what you had already spoken about, I'm just showing this image which you had drawn, Jay,
Yeah.
because I believe that the eye does not see what the mind does not know, especially in terms of ultrasound. And majority of gynecologists don't do their own ultrasound because they are still not tuned to different different appearances of different tissues of the anterior abdominal wall. So you beautifully described, the layers, and I think it's only a matter of time. We just go on practicing and you'll be able to make out difference between the adipose fatty layer and the rectus abdominis. So this is just one image I wanted to show, Jay. Now, the other thing which you beautifully brought across, the point was about how if you just leave okay, so you can see over here, this is a patient with multiple scar, multiple abdominal wall endometriosis, which was not treated with Dynogist, and you can actually see the sinuses develop over here for this patient, and she came to us at this end stage. So this is also another very important point I think everyone has to take home, is not to treat patients like these with medical management, and otherwise this is going to be the final picture of the patient. And one more thing, Jay, is what we often see associated with scar endometriosis is also an adherent abdominal, adherent uterus. And you have operated many of these patients at our hospital. And as you rightly said, these patients are treated with Marinas and Dynogist, and this is absolutely a no-no for this particular pathology. So I just wanted to bring this also into attention, that when you are searching for scar endometriosis, also we should look for adhesions and associated pelvic endometriosis. So just a few things, Jay, I wanted to bring forth to everyone's attention, and I think we'll maybe take a few questions.
Yeah, Shilpa madam, you can go ahead.
Can't hear you, Jay.
Yeah. So one of the important points that we need to know as the surgeons and also as people who are doing scans for this patient is the differential diagnosis. So which Dr. Vismay again pointed out, it could be suture granuloma, sometimes it could be just a lipoma over there. So how do we differentiate whether it is scar endometriosis for sure? Because many a times we need to have a surgeon who has to be there for mesh repair if required, because the depth we are not very sure when we do the scan. Sometimes it will be deeper than what we have actually thought.
Visma, you can answer that question.
Madam, so for suture granulomas, I am of the firm belief that if the nodule for a scar endometriosis is always from my experience, I have seen these are all irregular margins. A nodule which is a small one, which is only located to one layer, not going inside, and has a very regular round border, or it's most probably going to be a suture granuloma.
Yeah.
And again, that nodule, as sir said, is not tender. The patient won't be complaining of any pain. Of course, if you press very firmly, because it is deep, it's some suture, you will feel like that. And the thing is, more probably it will be on the sides, on the angles, because that is where usually we take our sutures. The knot of the suture ending will be there at the ends. So this may correlate. But again, as you said, fibrosis and this and vascularity is also not there in a suture granuloma. If
Yeah.
you put that vascularity, it won't go. So these are
So
the
is it
points.
better to do the scan? Is it better to do the scan on the day of the periods, like during their periods time, because the scar endometriosis will have more symptoms during the periods?
No,
No
madam,
correlation.
no correlation, because that won't work for a patient who does not have that kind of a symptom. Most of the patients have pain indefinitely. They are complaining of pain that they have in the scar. Also, one point I need to add in here is that clinical history making while doing the sonography is very important, because we have all these patients who come to us with pain in abdomen. Okay, so we have pain in abdomen. I do a scan. I look for the uterus, and we do endomapping, extensive TVS. We just see that the uterus is adherent to the scar, nothing else, and then we come out. Okay, but now I'm regularly asking all these patients to show their abdomen and whether they have a scar or not. Okay, by just palpating the scar, then the patient is winces, and then you catch a diagnosis of a scar endometriosis, which was completely missed, or we had not looked at it because we were so engrossed with finding endometriosis in the pelvis. So I think that is a very small point, that when a patient says abdomen, I don't think some patients are not that educated to tell you that where it is. So if they say, okay, that is there, and of course you will feel some nodule in the cesarean scar, if of that size when the patient is complaining. And yeah, so I think that is
Shilpa
one
madam,
more.
I just wanted to add one thing here. See, you both mentioned about the rounded, clear margins, right? The margins are absolutely clear. When the margins are well defined, the other differential we should keep in mind is something called as desmoid tumor. Now, Vismay and myself have seen these cases of desmoid tumor in scar endometrioma. First time when we saw it, it was a shock for us because we did not think it is scar endometrioma. We thought
Yes.
it is some abdominal wall muscular tumor or something, and we got a frozen section done because we have the frozen in-house, and we realized that it is desmoid tumor. Okay, the problem with desmoid tumor is after you do your surgery, desmoid tumor usually should be sent for local radiation because it has got smooth muscle tendency of coming back. So even if you operate very nicely with a mesh, you will have a desmoid growing back on the mesh, understanding, and coming back to you. So that is just one very rare thing which you have to keep in mind. It is not very frequent, but if in case it is a smooth margin, large growth on the muscle, please rule out desmoid tumor. Do a frozen section. If it is a desmoid, make sure that the patient receives post-surgical radiation therapy for as a local radiation to reduce the recurrence.
Jay, we were also discussing that desmoid tumor, we must think of it if the scar endometriosis recurs very fast after
Very fast.
primary
Yeah.
surgery.
Yeah. If it recurs very fast, try to rule out a desmoid tumor.
Okay. Yeah. So does the scar endometriosis always have to be in the scar? Can it be a little away from the scar?
It is never in the scar, madam.
Never
It
in
is
the scar.
almost always going to be away from the scar only.
Yes, yes. It's a very important thing to tell everyone. This is a good message where we don't see the scar, because when we are doing the scan with the linear probe, we try to go along the scar line. So we have to just check wherever the patient is saying that she has the pain, we have to actually take our probe there and press it a little, and then we will know if there is any nodule or not.
That is very important. One more thing which I think I must add is what we have started to do very frequently now is that this same small part probe we use while doing surgery. Okay. So that means any small satellite nodules which are present in and around, no, 7 millimeter, 4 millimeter, 3 millimeter, everything we can take out while doing the surgery. And that is a very important point to reduce the secondary recurrences of this particular type of tumors.
So once I had this, like there were some 3 scans which all said that it is scar endometriosis, and then we posted her for surgery. But then unfortunately, like, I mean, there was nothing there. There was no scar endometriosis. Like we got the intra-op ultrasound, did all the circles and everything, but we were not able to locate anything at all. So such mishaps. But patient was very happy that she got the surgery done. Whatever pain she had before, the pain all went away
That
because
is
she
because
got.
you touched her, no? So any which way pain will go.
Be quiet. So in such cases, I think it is extremely important to, I think we should also tell, like, honestly, that there was nothing and we did the surgery, but I don't think, because any which ways we are sending whatever we are removing for biopsy, and it will come just as a fat layer or some tissue without any evidence of endometriosis. Has it happened to you?
Nothing like that has happened so far, because what we normally end up getting, as I told you, madam, is the recurrence of the scar endometriosis, which has already been operated once. So
Mesh
maybe
fibrosis.
maybe that is the reason why something like that happens. But I think one thing is very important, like how we have oncopathologists, no?
Mm,
Like that, we also should have endopathologist.
mm,
Okay. That
mm.
is because it is very, very important to make sure that the guy who is reporting the frozen reports or the reporting the histopathology reports, okay, it is very important that they have some knowledge of the anatomy and some knowledge of endometriosis. Otherwise, instead of stromal tissue, they can sometimes by mistake report it as fibrotic tissue. And when it comes at fibrotic tissue, it is a very much confusion in our mind. Okay, very,
Correct.
very much confusion in our mind. I want to answer one question in the chat box. See, remember, if you are an obstetrician and gynecologist and you are reporting on scar endometriosis or abdominal wall endometriosis, it is absolutely allowed. Okay, there is no problem in reporting gynecological ultrasound if you are a trained gynecologist. You cannot be a general surgeon and report on this, but you have to be a trained gynecologist and you can easily report. There is absolutely no problem.
Okay. Yeah, that's about it. Thank you so much, everybody.
Just one last question about recurrence rate post-surgery, Jay, because this is a counseling challenge. What do
Yeah.
you counsel your patients regarding recurrence post-surgery?
So we have a document. You have seen our documents, right? So we have our documents where complete excision of scar endometriosis, we give them a rate of recurrence of 1%. Okay. And a 10-year follow-up. The patient has to have a follow-up once every year for the next 10 years with us. No post-surgical medicines. You don't remove a scar endometriosis and put Mirena. You don't remove a scar endometriosis and give Zoladex, Lupride, OCPs. Nothing. Once the scar endometriosis is removed, if there is no associated pelvic pathology, nothing needs to be done. But there is one very important thing, and I think Vishma should have mentioned this. In quite a lot of patients where there is scar endometriosis, you will have something in the peritoneum. You will have a peritoneal deposit, you will have an elevated CA125, you will have some ovarian cyst. It is very important that along with scar endometriosis, you clear the pelvis. That means you clear the endometriosis. It is very, very, very important. One more thing before we conclude, I think we must talk because that is a very important point. If in case somebody comes to you with a 3 centimeter scar endometrioma and tells you that the patient is painless, okay, it is a painless nodule. Okay, that means most probably it is not a scar endometrioma. Okay, or the patient is Bahubali, one of the two. No other differential diagnosis is possible. The highest amount of stupidity which we can do in our career is doing FNAC for these nodules. I've seen these reports very, very commonly where we put a needle, create a sinus tract, do an FNAC, and then give Dynogest. I mean, really, really, I mean, I cannot imagine how we do such type of things. Okay. What is the point of proving if it is a scar endometrioma? Just open and do excision biopsy. Simple. Wide local excision, remove everything and send it for biopsy. Even that will prove only. Because even if you do an FNAC, then giving Dynogest is not an act of wisdom. It is an act of the highest order of stupidity on a sinus tract. So please don't do that. Please don't do that. And I think that is a very important take home point from the things which we end up seeing. Okay.
Jay, have you also noticed that patients who have severe pain but a very, very small scar endometrioma, they
Yeah.
can put on medical treatment for long because it is too small
Yeah.
to, blame the pain on that particular
Yeah. So
patient?
remember what the guideline states, irrespective of the size, if the patient is in pain, that particular thing requires surgical removal. It requires surgical excision. That is the guideline. Okay. Kindly let us not form our own guidelines. As far as this is concerned, these guidelines are freely available on Google Gemini, Chat GPT, and across various other bodies for anybody to simply go log in and verify. Okay. It's very easily available now.
One point, sir, I think we also have this because we do a lot of scar endometriosis, madam. I think the follow up of such patients should be done by yourself. You should not, you should ideally encourage the patient to come to you because such patients, when they go to other patient, other doctor, radiologist, particularly, they report the mesh which has been put in the patient. Sometimes the patient do have some kind of pain since 2 and 3 months, and as they're very anxious, they go to them, they do the scan and they come with you with a report that the scar endometriosis is still inside and you have not removed it properly. But probably in most of the cases, me and sir have seen, these are all cases of mesh fibrosis. The mesh which is seen, you can see the white glistening layer of the mesh, and there is some amount of fibrosis on it. And the reporting is done by the outside radiologist as it is the scar endometriosis because they have to report something of the pain of the patient. So I think all these patients need to be counseled and to be diagnosed or to be reported by you only. I think that is one more point I should put forward.
Okay, guys. I think if we are done, thank you so much. Anybody wants to conclude with anything? I thank each and every one of you for joining. More questions you can ask us on WhatsApp.
Thank you so much.
Thank you. Good night.
Thank you.
Good night.
Good night.